Hi, my name is Brandy Watkins. I'm in my first semester at West Texas A&M University, the graduate program, studying to be a family nurse practitioner. I've been a nurse since 2014. I got my RN. I worked at the Retirement Ranch, which is a skilled nursing facility, and long-term care. So we did a lot of rehab patients. I really enjoyed that. I've been at Plains Regional Medical Center, which is our local hospital, since 2018, and I'm a PACU nurse. So we do post-anesthesia care unit nursing, and I absolutely love all of my coworkers. I love our surgeons and our CRNAs, which are our nurse anesthetists. They're absolutely amazing. Today, I'm going to present to you a PowerPoint on rheumatoid arthritis. I'm really interested in it because I myself have been diagnosed with it. And so doing further research and understanding, this is for our advanced pathophysiology class, which I'm really enjoying because for each and every paper that we're doing, we're able to dig a little bit further into the disease processes and learn. All right, let's get started. Let me see. Ooh. Hang on just a second.
Click harder.
Thank you. Okay, the objectives of this PowerPoint is to explain the pathophysiology and clinical manifestations of rheumatoid arthritis. By the end of this PowerPoint, I hope to be able to educate everybody on risk factors, what diagnostic testing, and to educate on patient treatment. The pathophysiology of rheumatoid arthritis. Well, number one, it is an autoimmune inflammatory disease. It's basically the immune system attacking the lining of the membrane of the joints. Inflammation and painful swelling attacks many joints all at once. There's different phases. The initial is the acute inflammatory episode, that it will become inflamed and then all of a sudden it will go into recovery. The cycle will repeat itself and be reoccurrent, activating the cell-mediated immune response, the activation of the immune system. This releases inflamed cytokines and causes joint destruction. Exacerbation phase involves inflammation of the synovial tissue, causing thickening of the synovium, harming cartilage and the bone, which is the destruction. The clinical manifestations of rheumatoid arthritis are, it's presented in exacerbations and remission. So it kind of comes and goes. It's a gradual progress over time affecting multiple joints. The joints can be red, or they don't necessarily have to be red, or they can be swollen, painful joints. It reduces the flexibility and mobility, and it's primarily in the hands, knuckles, and fingers. I know particularly when we think about rheumatoid arthritis, we think of the elderly and the deformity of their hands. You know, it's a definite sign that you know, okay, they've got RA. But even young people like myself can experience this. Other clinical manifestations is that as this disease progresses, the joints can become deformed. Like I spoke about previously, the nodules can become palpated. I know for me particularly, the first time that I was like, something's going on, is that my pointer finger was red and it was swollen and I couldn't bend it. And I was like, maybe, you know, it needs to be popped. So that was the first indicator that I had RA. Some other symptoms that people can experience is anemia, fatigue, anorexia, weight loss, and depression. I'm definitely tired a lot, and I have been noted to be anemic. Definitely not weight loss. That would be nice. Okay, the diagnostic labs. The first thing when you have a patient that you want to check is their history and physical. Find out what their signs and symptoms have been, how long they've progressed for, how long they presented themselves on and off. Definite defining factors sometimes would be the serum rheumatic factor, which, I mean, you would think that that would be the thing that would identify RA, but not necessarily. For me particularly, my ANA was high, but what I learned through research in our book is that the ANA is usually not high, which is a serum anti-nuclear antibody. It's usually not high in RA patients, but in 1/3 it can be high. They can also do the synovial fluid analysis. Joint x-rays don't show anything right off, but later through the progression of the disease, they can show joint space and bone erosion. Definitely a CBC, a complete blood cell count with differential would want to be tested, their platelet count, liver and kidney function. Because like we said, RA can attack all organs. So early identification and treatment is key. Risk factors, the genetic risk factors. There's the human leukocyte genes, the HLA that participate in self-protein recognition. A big one is female sex are more likely and family history. But back in the day, I don't think as many people got tested as they do now. Like, I don't think I have any family history of RA, but I know, like, personally, my mom has had some issues, and so I'm sure if she got tested, she would have it. There's epigenetic modifications, methylation changes, variations, regions, genome, and fibroblasts, like from the synoviocytes, the FLS joints. This is an increased awareness that people need to be aware of to monitor for RA to be treated adequately. Other risk factors, the genomic, there's the STATF, which is the gene involved in regulating the immune system process, implicated in the autoimmune complex. There's also the TRAFI-C5, which is significant in the role of promoting chronic inflammation. Treatment. Treatment is key in early identification of rheumatoid arthritis. One of the big ones that they first start off with are DMARDs, disease-modifying anti-rheumatic drugs, to decrease disability. Early treatment can be effective in, being able to treat and prevent the joints from further corroding and causing disability in some form. Methotrexate can be given orally, subcutaneously with folic acid. It's definitely great to give these two together to watch their effectiveness. Other treatment, specifically the multidisciplinary approach, is you need to have all hands on deck. Not just a rheumatologist, but it's great to have rheumatology. You need to have therapists, occupational, physical therapists, dietitians. Diet is key. I know specifically for me, when I try to cut out like meats, fried foods, fat foods, and all the research I've done is like the Mediterranean diet. The healthy, the plant-based is key in any autoimmune disease processes. It also talked about podiatrists, which I don't see one, but I'm highly interested in counseling, because it can affect your world and your lifestyle and being able to control your disease and be able to function with your family and your friends and your work environment. And then also orthopedic surgeons if needed. Patient education and teaching. The biggest thing with rheumatoid arthritis that most people experience is first thing in the morning, stiffness, pain in their joints when they first get up. Exercise. Moderate to mild exercise first thing in the morning is highly beneficial. I know if I have time to get up and work out, I feel great, or like a warm bath because I feel stiff or achy. Definitely recognizing when I need rest is a big thing. Getting adequate sleep, 8 hours, 8 to 10 hours would be amazing for RA or any autoimmune. No activity that causes stress on the joints. I know for me personally, I love to do like my Peloton, and I have to do weights like this, and I've had to see an orthopedic surgeon several times for putting stress on that joint, and I've had to get some injections. So that's a no-no. Relaxation, whatever that looks like. Yoga, whatever is relaxing and calming, massages, heat and cold therapy. Also utilizing supports to maintain proper alignment, like with hands and stuff or whatever's needed. I know my rheumatologist has given me some braces to wear at night on my hands, but I have not been that compliant. But definitely in disease progression, and it's highly beneficial. Okay, there's also non-pharmacologic and pharmacologic, like we just discussed, the DMARDs. I know for me personally, I take an anti-malaria agent, which is Plaquenil, which I was kind of hesitant on, but then, you know, COVID, so everybody wanted it. So I take that at least once to twice a day as ordered. Lots of the patients that I see do methotrexate, you know, corticosteroids or NSAIDs, non-steroidal anti-inflammatories. I do try to take Tylenol arthritis. It's highly beneficial. It's not great on the liver, but whatever you can do to take that would be great. And herbal therapies. There's all kinds of herbal therapies that you can do, over-the-counter things. And I'm always inquisitive of patients that I interview for surgery when I work in the office, like if they have RA, what they take, or I'm learning about new drugs and therapies that they can take. I hope I have helped you guys and taught you a little bit about rheumatoid arthritis. I know for myself, I've learned a lot. I've enjoyed this class, and this is actually my first YouTube presentation. So I'm enjoying it. Thank you. Have a great night.